Okay. Yeah. Uh-huh. Mhm. Okay. 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 Uh-huh. Okay. Okay. Okay, sure. All right. Is he back in the ICU? I'm sorry, where are you going to get him to? A Tower 8. Okay, we'll see him, no problem. Okay, thanks a lot. So speaking of Rocky Bluford, well, so Rocky Bluford is back in the ER from Moss. Last night, or at some point recently, he had a superior vena cava syndrome, which was treated successfully. IR thinks he should be on heparin, and in fact, he has a segmental obstruction and then subsegmental obstructions on the right side, segmental on the left, lower. And they want to know if it's safe to anticoagulate him. So he's in the ER. He's probably going to be admitted to Tower 8, not to the ICU. So I don't know if we should see him or consult to see him. I don't have any problem if you want to see him, and we'll staff him.
I'll ask how busy are
Just got 5 minutes.
Including Rocky Bluford?
I don't know.
so I'll let like know that.
I mean, we know him. It's a simple question.
She knows him. Everyone.
Everyone knows him.
But yes.
I'm okay. I'm okay under any circumstance, as long as one of us sees him. Oh,
And she doesn't. Yeah. Maybe
she doesn't know him. We don't. Yeah. Let's not. Well, let's take care of him. Even if consult resident wants to see him and staff him with me, I don't care. Yeah. I mean, that would be 5 minutes for me and an hour for her.
yes. Maybe we can just walk over together. Then I can write it.
Yeah. Yeah, so there's different websites you can use. There's ones like Flickr and Photo Bucket. I think those are 2 main ones. But if you have an account like Google or Gmail,
I have a Gmail.
yeah, like Gmail has its own photo app within Gmail, and you can upload photos to that, and you can share a link with friends. Like you can create an
I
album.
want it to be generally available, though. No.
Just put then you'd have to probably create your own website and put photos there, and then hope that people can find it.
Do you put metadata? Because it's metadata that will find it, right?
Yeah, so your own private sites, your own private album isn't going to have that. But if you put it in the public space, like on your own, on a website that you create with photos, then people will be able to search for that. Although it might be difficult.
Sounds complicated.
I think it's much easier to just
Join
create,
Facebook.
Yeah, either Facebook or create your album on either Google or, I think Apple has iCloud, which has photos too, or Dropbox or Flickr. And then you can send that link to the album to whoever. I think it's very difficult to create something in the World Wide Web for someone to search, unless you're connected to some sort of like website or journal or news organization, it's really difficult to just search for a picture created by someone.
Really?
Yeah.
I
Right?
don't think so.
What do you use?
What do you mean, like in terms of privacy?
No, just like to search.
I want to make it totally public so that if someone were to search for,
and want someone to be able to find it, not using social media, just general public. Like
Well,
you-
if somebody Googles you,
yeah,
you'll find it.
people would have to like know exactly what to look for.
Yep.
Yeah, because you'll be amongst like millions of other pictures. And
Sure.
it's gonna be hard.
But that's
to,
why I was asking about the metadata. There are not going to be a lot of other people who have a, refractive pattern from eclipse, solar eclipse.
Like if somebody Googles eclipse or something and
Yeah, if you label that, then
in images, you
No.
will find.
yeah, if you label that, then yeah.
Even in the Google photo app.
I don't know.
Oh, you Google
I don't
Drive.
think those are
know,
public.
because Google Drive is only yours.
It's your
Google
own
Drive.
private album.
But it's good. It's true. Yes, yes, yes. It fixed it. I don't know about fixing people, but we just heard that. Yeah, that's it. Okay. If the lady would have come back to me, yes,
She didn't have a stroke, right? She had a small
she had a dog.
dot. It worked.
Also, Dr. Newman, you know that lady you saw in ED, the one with the aphasia and the one who got the thrombectomy? So when they removed the clot, they said the underlying left MCA was tight, and maybe that's what made her have collateral, so that when the clot went there, she didn't fully infarct. So they said that this week we should get Dr. Brady to do an IR consult and put a stent in there. Dr. Roby over the weekend said it sounds like such a bad idea because she's fully fine right now and has collaterals, and it would be very
He
sad
won't
if
do
something
it.
bad happened.
Paul won't do it. Yeah,
Okay.
he won't do it.
So I just put in my note that she can go home. I didn't say do an MR perfusion and do it. I asked my to do another.
Although I think that is the use of that. That is the, so y'all are always wanting to do perfusion, and I keep saying, no, this is when I would do the perfusion. When you have a
Yeah.
fixed stenosis and you don't know how good the collaterals are or not. I mean, that's what it's good for.
Yeah.
That's its most use, its best use.
Okay.
No, I'm not saying that she needs it. I'm just saying, I also don't know, well, I'm glad that they did the thrombectomy and she did really well and that, made life easier. I don't know that she would have not have done well if we left her alone also.
I
Truthfully.
don't know.
Because of the collaterals.
Yeah, because of the
I
collaterals.
think that until she had the TIA in the ED, it was one way, but when you were walking by and that time she was having the second TIA, you caught it.
So she was completely normal before
Before
I
you-
walked in there,
Yes.
I mean,
Yes.
completely normal.
Yes.
No facial,
NIH
no language
zero,
at all.
No facial. And after you left, the facial group resolved again.
Yeah.
So Dr. Jesus was like, oh, she's completely fine. I was like, well, Dr. Newman was here 15 minutes ago and she had a facial group and she was not speaking properly. And she's like, well, that was a second TIA. And then she got very much like, we shouldn't even wait for an MR. We should just, before she does it again. And they did find a clot, so.
Yeah. Well, there's no question that, the proof is in the pudding. She did very well.
That was an amazing turnout for that patient.
Great.
It gone so badly.
The Terry Madelon is very good, the chair. He's very good.
Doctor, it wasn't him who did the thrombectomy.
Bauer.
Dr. Decotis?
Oh.
Yeah. And he did it first class. He was showing me the image. I sent it to you, right? I sent you the picture. You're probably so busy on the beach.
Yeah, so busy on the beach is not likely, but so relaxed on the beach might have.
Yes, with your phone somewhere far away.
Yes.
Yeah.
We did. I mean, it was like eating. Well, we didn't drink that much. We ate a lot of food. So is Elec coming? And who else was not here this morning? Was it Elec and who
This
else?
is it.
Where's Lakshmi at?
But
Oh,
we
she's
have
at,
been-
oh, that's right.
Ask Elec if she's coming, okay.
I saw Lakshmi earlier. She was meeting with Dr. Roby too.
Oh, yes, we had a meeting.
Well, then ask Lakshmi if she's coming.
No, she's at St. Chris today.
I see.
She was just there for
Do I need to do anything here?
No, you're all set.
Okay. And online. So I hit, I don't know. I'll just do that.
Dr. Newman, how did you find out about Rocky Bluford being here?
The transplant team called me.
Then you should see.
Yeah, I don't mind. That's what I'm saying. I don't mind. I'm saying,
All right.
no matter which residency. I left this lecture alone. This is the original one that we gave back in 2008. This has been a topic of actually active research at this point. Maria and Stephen are both going to participate in a research study that grew out of my interest in causal inference. So, and the direction that I've taken has gone very different than this lecture, but I left the lecture alone because my thoughts are not really totally formed yet on this topic, but they're definitely different from this.
She's saying if you could start because she has 5 consults.
I know, but sorry, but I thought we agreed that noon conference is the conference.
She's on her way out.
Okay,
It's
good.
going to be a bit late.
So, first of all, the point of this, is does an association change to causation? So if you want to say that something causes something in medicine, what are you saying? That hypertension causes stroke, that diabetes causes stroke, that ApoE4 causes Alzheimer's disease. And did I go over my causation little analogy with you, where I was driving along? So I'm riding a bike, okay, on a country road, and I see a squirrel. I'm not paying much attention to the road. I'm enjoying nature, and I see a squirrel come running down the tree. And I think that the squirrel is going to come out into the road, so I swerve to get away from the squirrel, who doesn't come into the road at all, by the way. But when I turn, my tire catches in a rut, and I fall. Okay? At the same time, by the way, a bird is flying up above in the tree top, which I didn't even notice. Okay? And the question is, what caused the fall? And to me, the answer is completely obvious. Okay? Gravity. No gravity, no fall. Right? It was a necessary condition for the fall. All right? So, well, did the squirrel cause the fall? It was like the squirrel didn't, all it did was run down the tree. Did I cause the fall? Did the rut cause the fall? So how do you think about causation? That's really the problem. And in particular, in this talk, we're building on epidemiologic studies, not experiments, but epidemiologic observation. How do you know that smoking causes cancer? How about that? Right? Has anybody ever done a double-blind randomized controlled trial with smoking, cigarette smoking? Obviously, the answer is no. Okay. There are animal studies. There are all sorts of other biologic studies, but we don't really have any experiment that shows that smoking causes cancer. Okay? We don't. So all of that is based on epidemiologic data, and that's what we're going to talk about now. So to understand the criteria that assess the strength of evidence of epidemiologic studies of association is a very important word, and the distinction between association and cause. And then we want to look at the principles for inferring causality, and the AAN has some standardized approach to this. So when you have two variables, which could be hypertension and stroke, all right? Blood pressure, you have a continuous variable. Stroke is a dichotomous variable, right? So the question is there any relationship? You have two variables. They could have no relationship whatsoever, in which case they're going to be independent of one another, or we may find that they covary, that one is dependent on the other. But even if one does depend on the other, the question is it a causal relationship or simply an association that is not a causal relationship? So, for instance, my wife wears a two-piece bikini on a sunny day, right? And every time, if you look at how often my wife wears that particular bathing suit, you find that it's more, she wears it more on a sunny day than she does on a day that's overcast. Okay, there's a Rehoboth Beach analogy, right? Okay, does the sunny day cause my wife to wear that bathing suit? Okay, so you see the problem. So it can be causal or not causal. And what we call a risk factor indicates that there is an association of the preceding condition with the subsequent event. An association. That still doesn't mean it causes it. Does obesity cause, here's a better analogy. Does obesity cause stroke? Is there, let's ask another question. Is there an association between obesity and stroke? Yes. Okay. Does obesity cause stroke? Right. It's like, I need to think about that. Why? Why is that hard if there's an association? Why are you having a problem with that? Well, because there might be an association that is secondary to other conditions as well, in which case there would be confounding, right? That obesity is associated with hypertension and also cigarette smoking and also hyperlipidemia, okay? So it might be those things which are causing the stroke, and the obesity is simply associated with those, but obesity in and of itself does not cause stroke, okay? So we're talking about when does an association become causal? When do you say that, and the question is, here's the question that we were just talking about. Is obesity associated with stroke? So, yes, you have more obesity, two variables, obesity, stroke. Obesity is associated with stroke, okay? Does obesity cause stroke? Like, I don't know, because obesity is also associated with hypertension, diabetes, metabolic syndrome, hyperlipidemia. Okay? So I'm covering, so we may not get very far. Call me someone. So here's the question. In what circumstance do we pass from an observed association to a verdict? I love that, a verdict of causation. And this is by Bradford Hill. This question is raised by Bradford Hill. And this has been a topic, causation, in my recent research. Let me tell you, I mean, Aristotle was not the first to think about causation, although he did a good job at getting things organized. All right? This has been, people have spent a lot of time on this problem, okay? But we have a particular problem in medicine because we're not dealing with experiments, all right? So we are dealing with epidemiology, and there the relationship between association and causation is even more difficult. So what does an epidemiologist call a cause? So a cause is an antecedent event, it comes first, condition or characteristic that was necessary for the occurrence of the disease at the moment that it occurred, given that the other conditions are fixed. Now, that may seem reasonable to you. It doesn't work at all, okay? So is hypertension Would you consider hypertension a cause of stroke? Yes. Okay. Now, is it necessary that the patient be hypertensive in order for them to have a stroke? No. So then this definition doesn't work. And that's all there is to it. Okay, let's try again. In other words, a cause of a disease event, we often use the word event. Does A cause B? Is a factor A cause event B? That's the way you talk when you're just doing logic of this problem. At any rate, in other words, a cause of a disease event is an event, condition, or characteristic that preceded the disease event and without which the disease event either would not have occurred at all or would not have occurred until some time later. And again, this definition simply doesn't work. For the same reason, it doesn't get you very far. So this is a thorny problem. On the other hand, the media loves what causes stroke. New cause found for dementia, right? You know what that was? That was vascular risk factors. And this Sally showed me on Friday's New York Times. New cause for dementia. It's vascular risk factors. It accelerates okay. Complexities of causality are often oversimplified. That is a gross understatement. Okay, and there's a distinction between association and cause, and they may become unclear. So we're going to take, right from the start, an example, okay? And the example is an interesting example, and that is, does vitamin D cause MS? Vitamin D deficiency cause MS, all right? So people talk about this a lot, right? So let's look at the data. So first of all, Michael starts on CNN, right? So this is, and there's a posted CNN, vitamin D may lower MS risk. Okay, and what is the evidence? So we're going to look at 2 papers, all right, and they're epidemiologic studies. So this is it. We do the systematic Medline searches, and there's a total of 2 articles. Which was, if you do the same search for heparin and stroke, you will find 2 articles. That's the total evidence related to stroke and use of heparin. There are 2 articles. All right, first study is this one by Munger. All right, the design is a prospective cohort. Do we like prospective cohort studies? Generally, they are the highest form of epidemiologic study that you're going to get to. All right, the subjects are, if you want to look at how many, we're judging the strength of this article. There are 188,000 female nurses in the United States. Who were followed for 10 to 20 years. How does it sound? Are we going to have strong data when we're done with this? Pretty strong. That's a pretty big study. That's a lot of people who are followed, okay? What type of data will we get? Will we get incident data or prevalent data?
Prevalent.
Well, it's actually incident data. We're doing a prospective cohort. We're going to start with 188,000 nurses, women nurses. We're going to follow them for 10 to 20 years.
They are not known.
They are not known to have MS at this time.
Sorry, I understood aren't.
No, they don't have MS at the time. So this is going to be going to be a lot of data. Okay, what's the exposure measure? The vitamin D intake prior to diagnosis from self-reported dietary histories. Strong or weak? Weak. This is weak.
Self-report is always weak.
Yeah. The outcome measure is newly diagnosed cases of MS during follow-up. Going to be by the Poser criteria. And the findings, here's the result of the study, that in the group with the highest vitamin D intake, as self-reported, the relative risk of coming down with MS is 0.69, with confidence limits of 0.42 or 1.15. Do we consider this strong or weak?
No.
This is weak. It's not a big effect, and the confidence intervals +1. All right. And the vitamin, as opposed, and here, if you look at only those people who took vitamin D as a supplement and those who did not, you have a relative risk of 0.6, and you don't cross the confidence interval, although we don't know what the size of this sample is, who took the supplement, and how they got their controls and everything else. So we would have other questions. But there's a suggestion that there might be something here, but it's not strong. for the discussion, the quality of evidence. So that's what we're doing. Study number 2. The design is a case control nested in a prospective cohort. So what does that mean? What that means, this is a very common design. It's generally a fairly good design. It begins with a prospective cohort. So you identify a lot of people, okay, not because they have a disease, but because they have some exposure of some sort, okay? But then you go to a case control method. You go and find all the people within this prospective cohort who have the disease of interest, and then you measure their exposure. All right, so let's look at it. The subjects are 7 million military personnel. There's your prospective cohort. A lot of people, okay? 257 cases of MS were diagnosed during follow-up, and each was matched to controls. Okay. Then you work backwards from that group and their controls to look at their vitamin D. In other words, they didn't measure vitamin D in all 7 million people. Okay, they went and followed 7 million people. They identified 250 cases of MS and controls. You figure the controls are pretty well matched with the 7 million population, right? And then they took those 750 people and measured their vitamin D. Okay, so this is a nested case control.
So it's including all the MS patients, right?
All the MS patients and
So
their
that's
matched
your
controls.
Okay.
And their matched controls. And they're going to compare the vitamin D level. Now, in this case, the exposure measure is serious, okay? Because they're measuring it, okay? What's the problem with this?
We don't know if they were taking.
Exactly. You don't know if this is the vitamin D level at the point after they've developed MS. So strictly speaking, you don't know if the MS caused a low vitamin D or whether they stopped going in the sun because they got MS or anything else. You only know that when it was measured, it was lower. Okay, that's what we're going to find. But you don't know what it was before they got the MS. So, okay. The cases were confirmed. They were, and the findings were that for Blacks and Hispanics, all right, there's no association of vitamin D with MS. And among whites, there was an association, which was a fairly strong association with a pretty, confidence limits that do not cross.
But those Hispanics background or actually came from South America?
I have no idea.
That's the
Right.
case, then yes, we have our association
Right.
and all that stuff, and that's completely different. So.
Totally different. Okay. So, all right. So now the question is, do you think that low vitamin D causes MS? Or do you think that you can treat MS with vitamin D? Okay. So
Based on those
based on those studies. Okay. So the answer to the second question is obviously not. Even if the vitamin D was associated with higher risk of MS, and it's not clear that it is, but even if it was, it's a totally separate matter of whether you can treat MS with vitamin D. And I keep talking about the VISP study. So the VISP study was an interesting study that we participated in. That was Jim Toole. So this was about, so it was known, all right, that homocysteine, the study was about homocysteine. It was known from prior epidemiologic and studies that a high level of, so low levels of homocysteine were associated with an increased risk of stroke and heart attack. And more severe stroke and heart attack. That was known, all right? It was also known that if you gave people 25 milligrams of B2 and 2 milligrams of folate a day and 500 micrograms of B12 a day, that you could raise the lower, so it was the other way around, high homocysteine and stroke. You could lower, so I'm sorry, high homocysteine was associated with stroke. And it was known that you could lower the homocysteine with this multivitamin cocktail. Both of those things were known. But what wasn't known was whether lowering the homocysteine with this cocktail reduced the risk of stroke. And that's what the study was about. And the answer was no. You could not. We did not one bit. We re-demonstrated that high homocysteine was associated with stroke and heart attack. We re-demonstrated that you could lower it with the vitamin cocktail, and there was no effect on the incidence of stroke after you lowered their levels. When they were followed for incidence data for 2 years, it was an extremely carefully designed study in a large population, about 10,000 people. Okay? All right, let's get into this. Cause and effect are complex. An effect is a product of a constellation, I like this better, of multiple exposure factors, each defined as a component cause. This is now some of the terminology that is used. These are component causes. Hypertension, diabetes, hyperlipidemia are component causes or risk factors of stroke. And the same disease may result. Here's the problem with the old definition, that you can have the same disease result from a different constellation of component causes. A necessary cause is truly one that must be present, that must always be present to produce a disease. So, for instance, Duchenne dystrophy, right? You have to have a dystrophin abnormality, right? If you don't have a dystrophin abnormality, you cannot have Duchenne dystrophy. And that's all there is to it. So a mutation in the dystrophin gene is a necessary cause of Duchenne dystrophy. Sufficient causes are one which will, when present, definitely will cause the disease. So, all right? And even other necessary factors may not be sufficient, but one that is sufficient, okay, all by itself will cause the disease. And here are just some examples of, here's 3 different cases of tuberculous meningitis, and you can see how different they are. But one that has to be present is exposure to tuberculosis, right? But that might not, so it's a necessary cause, but not a sufficient cause. Just because you're exposed, I've been exposed to TB, I don't have TB meningitis. Now, it's Bradford Hill then who starts this in 1965. He's going, well, our observations reveal an association between 2 variables. And first of all, it's important to realize that he's beginning with an association. No association, then he's out, he's done. So you have to start with an association. So remember, this is epidemiologic causal inference. Our observations reveal an association between 2 variables. It's perfectly clear-cut and beyond what we would care to attribute to the play of chance. This is above and beyond chance. What aspects of that association should we especially consider before deciding that the most likely interpretation of the association is causation? So I think the word interpretation is really important here. Okay? This is a judgment which is being made by people. Okay? Sorry. Hi, Simon. Yeah. Okay. Okay. So I should just continue with this. Okay. All right. Can you come back up and rejoin them? Or too late? Okay. All right. Good. Without focal findings. Okay. So first of all, a valid findings of association are essential for any inference of causality. This gets lost. I know it seems obvious, it gets lost. No association, no causation, okay? What if I came up with a plausible mechanism by which vitamin D deficiency might cause MS? Then would that do it? I don't have an association, right? And I find that, if I take all of the vitamin D out of a Petri dish, the oligodendrocyte loses its myelin in the dish. I have now a mechanism, right? I have a biological information. Is that enough? Or do I need an association of vitamin D deficiency with the disease.
Association.
You need the association. Just because under some experimental condition, I can induce an event, okay, does not mean that this event would occur. And here, I'll give you an example. This is from all of this, my thinking was through the testosterone literature. There are finches. I give the finches 20 times the level of testosterone. I give them, testosterone undecanoate, okay? And I raise their testosterone level 20 times above the upper limits of normal. Then from these finches, okay, I take some blood and I see that thromboxanate 2 is elevated. And their platelets, when I test their platelets are hypercoagulable. They react too quickly. Have I proven that testosterone causes stroke in humans? No. But that's the argument that is literally the argument that I am arguing against right now. And that's what people are saying. And there is multi-million-dollar suits over hundreds of millions of dollars, okay, in lawsuits over that kind of evidence with no association whatsoever among the epidemiologic data. Thromboxanate 2 is elevated. Okay. Threats to the validity of findings of association must be considered. Bradford Hill said them. So selection bias. So you have to have an association which is free of bias and greater than that of chance. That's the beginning. That's when you start to think about it. You want to be free of measurement bias, confounding, all the things that we talked about. Remember, selection bias, that the referrals were, measurement bias, okay, that either you haven't completely defined your outcome or you haven't completely defined your inclusion and exclusion criteria, that you have confounding associations with other possibilities, okay, and that sampling or random error. Remember, that's random error is a sampling error. That's not random noise, okay. Evidence that supports and strengthens a causal inference includes a temporal relationship. This is all Bradford Hill. In other words, the exposure has to come before the event. I told you about in the hemorrhagic stroke project of cases where the person developed a severe and unusual headache, testified that they thought that they were catching a cold, and so took the phenylpropanolamine that night. The phenylpropanolamine didn't come until after their severe and unusual headache. Then a CT scan was done after they showed up in the emergency room the next day. Why did they show up in the emergency room the next day? Because taking the phenylpropanolamine didn't make them feel better. These are case records, okay? The ER notes are clear. So the exposure comes after the condition. So what I'm telling you is these seem so obvious, and they're ignored. They're completely ignored. Reproducibility, you have to do it over and over again. Strong associations, that is big numbers. You like to see a dose response curve, right? If a little bit does some, then a lot ought to do it worse. The dose response curve, okay? All these things and statistical precision, it's beyond the level of chance, okay? And they're very difficult to establish with a high degree of certainty from epidemiologic studies alone, which is what we're talking about right now. No randomized controlled trials here, all right? So it's extremely difficult. So you look at the qualities of the AAN is saying, then look at the quality of the observational studies and see if there are any critical threats to their validity, meaning biases are so likely that we don't want to be involved. Again, the hemorrhagic stroke project, where people were doing phone interviews and telling them why they were doing the phone interviews. I mean, just bias all over the place. And so the AAN asked us to classify their articles from strong to weak based on a level of evidence. And based on the level of evidence and the consistency and the strength and the statistics and a biologic coherence, they grade things from all the way from very probable to possible or U is insufficient evidence. And there's a lot of U's floating around, by the way. All right. So you look at the design. Was there bias? And we've been over this, okay? Were there classification bias, so, because of poor definition of outcome? Was there confounding? Confounding is impossible to eliminate in a epidemiologic study. You can only eliminate it. And actually, I've started down the road of this EBM 102 and contacted someone, the person that I worked with on the VIS paper that I wrote. Okay, when I was first author, the statistician was a woman named Hee-Jung Bang, and I wrote her, asked her to join the EBM 102 study group, which she agreed to already. And she sent me 4 articles that she and her colleagues have written with the problem with the randomized clinical trial and how how the randomized clinical trial introduces bias. I know. So I haven't read the articles yet. I was going away when I read them, but it's going to be interesting. At any rate, you eliminate confounding by good matching of groups or by a technique which we will deal with at some point in the future called propensity analysis. And propensity is a very good way of dealing with this issue. We will come to that. The class of evidence, the consistency, the effect sizes, the statistical precision, whether there's temporal relationship, and whether it's biologically consistent with what you know. Can cigarette smoking cause lung cancer? I take tar from the cigarette. I make a machine that smokes. I collect the tar. I take some of that tar and I paint it on the lungs of animals. Okay? They get cancer. That's biologically consistent. I take out elements. I do an extraction, an organic extraction of the tars, and I isolate particular chemicals. And I put those chemicals in their inhaler, and on a ventilator, and they develop cancer. Okay? That's biologically consistent. Okay? I can generate experimental data which makes it biologically consistent. Biologically basically refers to experimental data that is outside of humans. All right, so when we look at these articles, and we've already done this ourselves, we've put them across. The population was of the nurses study was 188,000 women. So we can only say that this study applies to women. We don't know if it applies to men. In the military study, it was huge, except you can guess that they're relatively young. Probably don't have a lot of 80-year-olds in the military at that moment. The exposure we said was a weak exposure. We didn't like it. This was a good exposure, but we didn't know when it appeared. The MS diagnosis we'll trust. The confounding we didn't get into. And so both of these studies were rated class 2s. So 2 class 2 studies associated decrease in vitamin D with an increased risk of MS, and there were no contrary studies. Both yielded a similar effect size, which was about 1.5, which is not a big effect size. We know that the exposure preceded the disease in the nursing study, but not in the military study, actually. And so, do we have evidence that it's probable? They listed as class 2, so probable. We saw what the deficiencies were. All right, and so I think where this becomes interesting is down here where it's italicized. When the derivation of experimental evidence is either impractical or unethical, and here he's talking about a randomized clinical trial, there comes a point in the accumulation of evidence when it is more prudent to act on the basis that the association is causal rather than to wait further evidence. So although I've pointed out skepticism in this particular pair of studies, I am a fan of saying at some point, we do have to say that cigarettes cause smoke. You got to say that smoking causes cancer, okay? That hypertension causes stroke. Nobody's done, well, it's not true that people did eventually do experimental. So you take a population, right? And let them go to run a 140/90 or above, and 140/90 or below. These experiments are done, and then see which group gets more stroke. Well, it's not, when the studies were done though, you didn't have all the modern agents. And it was not uncommon to leave a person with a blood pressure of 220 over 140 because, guanethimide was a horrible drug and made everybody orthostatic. So they were falling all the time. So it wasn't clear which was better. How about after a carotid endarterectomy? Should you leave them, should their blood pressure be 130 over 80 and above, or 130 over 80 and below? Which would be better for, I'm going to just say overall, I'll tell you what the experiment was. Which group is more likely to become demented? 130 over 80 and above, or 130 over 80 and below? Following, the only criteria for going into the study is that you had a carotid endarterectomy, no other criteria. Which group, if you follow them for 10 years, which group is more likely to have dementia? It's the low group. Yeah. Inadequate perfusion.
Yeah.
They've got,
But if you had already endarterectomy.
but the endarterectomy is your macro vessel and the micro vessels. I mean, I'm making that up. I don't, but that was the result of that study. Exactly. Yeah. You prevent strokes, but you increase the risk of dementia. So very quickly, all right, very quickly now, this comes from the AAN that you're looking at their class 1 through 4, where these have the highest risk of error, and this has the least risk of error, this has the highest risk of error. At the top of the epidemiologic data, we're not doing randomized trials here, at the top is a prospective cohort design. And when you do it well, I keep saying that, when you do it well, you come very close to a randomized clinical trial. In fact, there have been 5 first-class prospective cohort studies and that were followed by a randomized clinical trial. And in all 5, the results were the same. Same. The magnitude of the effect was the same. Everything was the same. There are no exceptions to that. All of the well-designed prospective cohort studies have always predicted the results of the randomized clinical trial. But these are well-done studies. They have everything in them that a randomized clinical trial would have, except randomization. Okay? Blinding, well-defined outputs, well-defined entrance criteria, bending over backwards to eliminate bias. These were well-done studies. Okay? And then and also to get into class 1, your study group has to be representative of the population of interest. And then you can see how, as you get to a retrospective cohort or case control, okay, where the study groups are still representative, your class 2, when you're dealing with a cohort or case control and the group is narrow, so then you're in class 3 data. So I think we're basically done with this. So then they have the AAN has this complex system of, you count up, like a Chinese menu, okay? You count up how many from column A and how many from column B, and then you figure out what category they are, okay? That's it. So I have to go join someone in the ER. When do you want to do the next one of these?
We have to finish this week.
Which is fine. We can put these off until after, all of the emergency. We can do anything.
We have scheduled for later this week.
No, but let me check.
And the other thing is, bear in mind that so let me raise this concern. All of the starting people will not have had this. And there were a lot of people who didn't have these also because they were away or doing night floats, that sort of thing. So if you want me to give the 1 through 7 again for those who didn't attend, I'm willing to do that and then pick up lecture 8.
Yeah. Well, we already have most of them recorded. I think there's one that we missed.
Okay.
So
There were 2 that we missed. And we can give those again.
Thursday and Friday.
I am available Friday, not Thursday, this week. Right. I'm going to be in Wisconsin on Thursday. So, but I can give it Friday.
Okay.
anyone who missed, we can add it on next, next like
Yeah.
July.
Yeah.
And we'll have like the whole set. People can watch it.
Maybe what I can do is I can give 1 and 3. I'm pretty sure those are the ones we missed. I'll give 1 and 3 for the first year residents.
Okay.
And then we'll expect that everybody else is going to catch up with the
Yeah.
others recorded.
Maybe I'll let someone know.
Okay.
She's yesterday and I'm like scheduling all that. So
Okay.
she can get all that done. I did it before because she was like so before, so that's why I took over. She's the one.
Do you edit these?
CPA?
I used to like crop.
Yeah, crop.
Yeah.
What?
Her blood glucose is 550,
It's in the
but she's not in
I just